PCSK9 inhibitor. But in order to understand that, we need to know what is the function of PCSK9. So this illustration is in the hepatocytes, extracellular space over here and intracellular space over here. The circulating LDL has to bind to LDL-C receptors for it to be able to enter intracellularly and undergo lysosomal degradation. This effect will cause a decrease in LDL, circulating LDL. Now, there are secreted PCSK9 in the hepatocytes, and this PCSK9 will degrade LDL-C receptors. So, the net effect of that is a decrease in the binding of LDL-C. There is a study about gain of function of PCSK9, which means the mutation results into more secretion of PCSK9, and it will degrade the LDL-C receptor so that less LDL will undergo lysosomal degradation. The next effect would be an increase in circulating LDL. So to correlate the increasing PCSK9 with that of ECS, as shown in this forest plot, those patients with high levels of PCSK9 have higher chest pain or ACS, higher hsCRP, which is a marker of inflammation, and higher triglycerides. So clearly, if there is increased PCSK9, it would lead to increased LDL and would lead to a high risk for acute coronary syndrome. And this is opposite if there is loss of function of PCSK9, because there will be more LDL-C receptor, and so LDL can bind to LDL-C receptor, and LDL will be degraded, and this will result into a lower LDL in the circulation. So based on this meta-analysis, those patients with lower PCSK9 or the loss of function of PCSK9 resulted in lower odds ratio for early onset myocardial infarction. And this was maintained all throughout the study. So it was consistent that LDL-C with the use of Leukomab based on this 4-year trial reduced LDL-C, and very nice results. It was able to produce a reduction of more than 30% in more than 99% of patients, and more than 50% reduction of LDL-C, more than 90% of patients. And in terms of reducing the major adverse cardiovascular events, Leukomab reduced it by 12.6% as compared to placebo of 14.6%, and this difference is significant. In terms of reducing the secondary endpoints, Leukomab also reduced cardiovascular death, myocardial infarction or stroke by 7.9%. The absolute risk reduction is 2.0, and the number needed to treat is 50 patients, all treated over 2 years. So looking at all the endpoints, it was only hospitalization for unstable angina, wherein Leukomab and placebo have no significant difference. All the others, there was in favor of Leukomab in terms of reducing myocardial infarction, stroke, and revascularization. So I'd like to highlight those patients who are at very high risk for cardiovascular disease. These are those patients with atherosclerotic cardiovascular disease, or if their 10-year risk for cardiovascular disease is more than 10%, and they have familial hypercholesterolemia, they have severe chronic kidney disease, or they have diabetes with target organ damage. So these patients with very high risk and high risk, you need to reduce the LDL by more than 50% from baseline, or an absolute reduction of the LDL by less than 55 milligrams per deciliter if they are at very high risk, but less than 70 milligrams per deciliter if they are at high risk. So in this meta-analysis, which they used the study or the trials that targeted a lower LDL of less than 55 milligrams all of these studies have consistently reduced major adverse cardiovascular outcomes. And that's why the new mantra is the lower the LDL-C, the better. And we have been consistently showing you that if you are using high statin therapy, you are targeting a more than 50% reduction of LDL-C. And if you add ezetimibe with high intensity statin, it would increase the LDL-C reduction by 65. But together with PCSK9, the reduction is more than 85. The absolute risk reduction is also reduced if we are able to achieve a less than 55 milligrams per deciliter of LDL-C. And this is the current guideline by 2019, according to the ESC, that if the LDL-C is not achieved within 4 to 6 weeks, despite high dose statin and ezetimibe, we can add PCSK9 inhibitors at class 1 recommendation. If the patient is admitted because of ECS and you approximate that giving high dose statin and ezetimibe will not reduce the LDL-C at your target, which is more than 50% reduction or absolute reduction of less than 55 milligrams per deciliter, then you can add or you can start PCSK9 inhibitor during hospitalization, and it has a class 2A recommendation. So I'd like to end the first case. He was a 52-year-old male who had an ST elevation MI and very elevated LDL. You tried to give a high dose statin and yet the LDL was not yet on target. And then the physician added ezetimibe, but still the LDL is not on target. And there was an indication to give a PCSK9 inhibitor. We will now go to our second case, and this is very common in our clinical practice. This one is elderly male, smoker, hypertensive, and diabetic, and came in because of chest pain and easy fatigability. The cardiac enzymes is normal. The ECG showed non-specific esoteric changes. The ejection fraction based into the echo was 52, and this is consistent because we see hypokinesia on mid-to-apical and anteroseptal wall and anterior wall. So looking at the LDL of this patient, also highly elevated at 213, the angiogram of this patient showed an occlusion at the distal left main, occlusion of the ostial left circumflex artery, and some occlusion here at the mid-left anterior descending artery. The right coronary artery is completely obstructed. So we have a patient with severe three-vessel disease with left main involvement in a patient who has diabetes and hypertension. Clearly, there is an indication for coronary artery bypass graft. So he underwent coronary artery bypass graft, and upon discharge, he was maintained on one antiplatelet, a dual oral hypoglycemic agent, an ARB, and high-dose statin. So after 1 month of follow-up from 213, the LDL-C is now 132. Yes, we have reduced by more than 50%, although the LDL-C is not yet on target because we want an LDL of less than 55 milligrams per deciliter. However, the patient is already complaining of muscle pain in his thigh. So what do we do? It is the most common symptom or adverse effects of giving high-dose statin. That's muscle symptoms. And the other adverse effects are liver toxicity, new-onset diabetes mellitus, proteinuria, and neurocognitive symptoms. So I'd like to see if the audience are familiar with statin myopathy. Please try to answer the correct definition. Is it A, myalgia, is a focal or diffuse muscle aches or weakness accompanied by creatinine kinase elevation? B, myositis is muscle pain with creatinine kinase elevation. C, myopathy is myalgia with CK elevation of at least 2 times the upper limit, and D, 3 times the upper limit. Please type in your answer. Okay, let us try to see the results of the poll question. So most of the patients answered letter D by 55%. So the correct answer to this question is letter B. So based on ACC guidelines, any disease of the muscle, we call it myopathy. But if there is a focal or diffuse muscle aches with a normal creatinine kinase, that's myalgia. If there is elevation of myositis, that's if there's elevation of creatinine kinase, that's myositis. And so muscle pain plus elevation of creatinine kinase more than 10 times the upper limit plus any organ damage, most specifically the kidney, then that's rhabdomyolysis. So this patient was experiencing thigh pain because of high dose statin. And so we checked the creatinine kinase, it was highly elevated at 876. So what do we do? What is our uh, next management in this patient? Is it A, discontinue his statin and start omega-3 fatty acids? B, discontinue atorvastatin at 80 milligrams for 1 to 2 weeks and do a re-challenge thereafter. C, check the creatinine levels and see if the patient developed rhabdomyolysis. D, discontinue statin indefinitely. Please type in your answer. Okay, let us try to see the result of the poll question. Most of you want to discontinue atorvastatin for 1 to 2 weeks and do a re-challenge. But the correct answer of this patient is, of course, to assess if the patient has indeed rhabdomyolysis, because the management will matter. A patient with myalgia, you need to check creatinine kinase, and once the creatinine kinase is elevated, you have to check for any organ damage, let's say kidney damage, and if there is elevated creatinine, because if there is kidney damage, the patient has rhabdomyolysis. And the treatment is, or you have to discontinue statin for over 6 weeks. After 6 weeks, we can start with combination of ezetimibe plus a low-dose statin, or we can use low-dose rosuvastatin and alternate on weekly dosing. Now, if a patient has myalgia and elevated creatinine kinase, but there is no organ damage, so no rhabdomyolysis, the management will be dependent on the level of creatinine kinase. If the creatinine kinase is less than, it's elevated but less than 4 times the upper limit, you only need to stop the statin for 2 to 4 weeks. But if it's more than 4 times, then you also need to stop the statin for more than 6 weeks. Then after that, you can add, or you can restart with a low-dose statin plus ezetimibe. But if the LDL is not yet on target, then there is an indication to add a PCSK9 inhibitor. So most of us would not restart statin in an elderly population who have complications from high-dose statin. But based on studies, those patients, elderly patients, whom the statin is discontinued, they have high incidence of cardiovascular death if compared to patients who have at least low dose statin. So in case 2, this patient had myopathy and then there is elevated creatinine. So clearly this patient has rhabdomyolysis. He was admitted for 5 days. IV hydration was performed and eventually creatinine went down to normal levels. The statin was discontinued for over 6 weeks and restarted on low-dose statin plus ezetimibe. However, after follow-up, although the creatinine is slightly elevated, but the LDL is not yet on target at 119. And take note that this patient is post-coronary artery bypass graft, diabetic and hypertensive, and so there is an indication to give a PCSK9 inhibitor in the form of Leukomab 140 milligrams subcutaneously every 2 weeks. So we are asking for the safety of Leukomab, and this has been laid out in Osler trial. They conducted this study for over 52 weeks, and it has shown really good results that most of the patients in the efficacy arm have continued with statin therapy and are all were on ezetimibe, and that most of these patients, regardless of the treatment arm, received Leukomab. And so the results show that these patients have a reduced myocardial infarction and stroke by 19% and 23% respectively. In terms of the outcome, the mean LDL was 140, but within 2 years, the LDL-C was reduced by more than 56%, and this was maintained in over 5 years with a mean LDL-C of 61. And looking at the adverse effects, it was stable and tracked lower over the treatment course, and the discontinuation of ibuprofen was because of adverse events was only 1.4% per year. So in the ibuprofen arm for 5 years, the adverse events reported were potential hypersensitivity, potential injection site reactions, muscle-related side effects, new onset diabetes, and neurocognitive related disorders. But if you look at the data, it was all of these were less than 10%. So in terms of safety profile, ibuprofen is safe. So PCSK9 monoclonal antibody are also safe among elderly, and this has been shown in this Odyssey trial that these patients who receive a monoclonal antibody more than 65 and more than 75 years old have uh, good safety profile. So these patients that needs PCSK9 are those there are groups of patients that can benefit from PCSK9. These are extreme high risk patients, meaning that they have 40% 10-year ASCVD risk, and if their LDL-C is more than 70, because they are at risk for stroke, they are at risk for heart attack and peripheral artery disease. Those patients at very high risk, meaning that the 10-year ACVD risk is between 30 to 39%, and if their LDL-C is more than 100 milligrams, and those patients at high risk and LDL-C is more than 130, they can benefit with monoclonal antibody inhibitor of PCSK9. So uh, trying to put up everything, if you have a patient with ACS or high risk for coronary artery disease, based on the American College of Cardiology recommendation, we need to target a less than LDL-C of 70, but less than 55 if the patient is at very high risk. By giving a high dose statin, you add ezetimibe if not yet on target, and then you add a PCSK9 inhibitor if not yet on target. So in conclusion, the therapeutic inertia remains to be a problem in managing dyslipidemia. Intensity of LDL-C lowering therapy should be based on the risk and baseline LDL-C levels. The greater the LDL-C reduction, the better. And statin, ezetimibe, and PCSK9 monoclonal antibody are lipid-lowering drugs proven to have benefit in cardiovascular event reduction and are safe in lowering down the LDL-C levels among these high risk and very high risk adult population, regardless of age. Thank you very much for your kind attention.
Okay, thank you, Dr. Mambulo and Dr. Romance, for that interestingly informative lecture. So now may I call on both of you again to join me here in the virtual screen for the Q&A portion. Dr. Romance? Okay. So let's see if we have questions from the audience. Everyone is welcome to type in your questions at the Q&A box at the bottom of the Zoom screen. If none, let me throw in the first question for the two panelists. Okay, so hey, Dr. Romance. So, Doc, what is the role of your fibrates in patients who have ACS or in patients who have high ASCVD score? Or do they have a rollback for these patients?
Fibrates? Sorry, the fibrates?
Yes. Doc.
Okay. Based on the guidelines, both American and European guidelines, uh, not much mention of the use of fibrates. The first line, of course, is the use of statin therapy, followed by the use of Leukomab, and if not, doon na papasok yung other non-statin as well as the PCSK9. So, of course, it depends. We should not be limited with the guideline because the way we manage patient is holistic. For example, if you have an ACS patient with an elevated triglycerides, although I think that's one way that we can add fibrates. Like in the study of the Dyslipidemia International Study, the Philippine cohort there, the Philippine cohort presented by Dr. Abola and Dr. C. Still, the Philippine doctors, on top of statin, they combine the statin with fibrates. So it's more of the general picture of the patient, not just uh, following the guideline per se. But as per as the guideline, nasa dulo yung use of fibrates.
Okay, thank you, Doc, for that wonderful answer. So we have here a question from the Q&A box. What is the cost of Repatha? I think Sir Carlo from Zwilig is going to answer it.
Hi, good evening, doctors. Thank you for this opportunity again. Currently, the cost of Repatha for one vial, it's 12,468. So, it's available po through a short click pen. I'm not sure if you will be able to see this like this. Yeah. Ito po yung short click pen natin. So, it will just be very easy for the patient to be able to administer the drug to him. Pwede po na siya yung mag-administer sa sarili niya, like how you do it with insulin. So, it's available po also through our sub-distributor Globo, Asiatico, nationwide. If ever you have patients po you think will be benefiting from Leukomab Repatha, just we will be giving po our contact numbers later in the program, so that if ever you can contact us and we could assist you and your patients, especially on the access and on administration. Thank you so much.
Sir, yung 140 milligram per pen ba yan?
140 milligrams po siya.
Okay. Thank you, Sir Carlo.
Salamat.
So another question here is I think for Dr. Mambulao. It says from an anonymous attendee, can we stop Leukomab once we reach the target, or should we continue for 5 years like in the Fourier trial?
Thank you for that question. We have to follow what's shown in the Fourier trial. Based on the guidelines, we still need to continue giving high-dose statin plus ezetimibe plus Leukomab for more than 5 years if we are able to maintain a less than 55 milligrams per deciliter. Based on the guidelines, the lower we target LDL-C LDL level, the better. And so if we can maintain a less than 55 milligrams per deciliter for more than 5 years, as long as the patient can afford taking all these three lowering drugs of LDL, then the better.
Okay, thank you, Dr. Mambulao. So are there any questions? I think wala na from the audience. Oh. So, okay. So, in summary, let's now go to the closing part. Dr. Romance discussed the Dutch criteria for your familial hypercholesterolemia and the need for your high-intensity statin for ACS patients. He also emphasized on follow-up schedule for the repeat lipid levels for these patients, He also mentioned on when to add your ezetimibe. And on the other hand, Dr. Mambula introduced a new drug for the management of your dyslipidemia, the PCSK9 inhibitor, producing at least 75% LDL reduction when combined with your statin, and at least 85% when ezetimibe is added to this concoction. And also, he mentioned the population who would benefit from this. Having said that, let us now call on our representative from Zwillig Pharma, Sir Carlo and Ma'am Erica.
Yes, maupay na gabi sa iyong tanan Eastern Visayas chapter for our PHA. So for today, I will be providing information about our brand Upata. So allow me to introduce myself. I am Erica Gomez from Zwillig Pharma Therapeutics, and I am covering the Visayas and the Mindanao. So allow me to share my slide. Hold on. Can you see my slides now?
Yes, Erica.
Okay. So again, good evening, and allow me to present our product, which is Upata. Our brand is Leukomab. And we always say we go beyond the statin co. Why do we say we go beyond the statin co? So actually, this is a study conducted by Reality Asia, and it says here that in a population of high cholesterol patients, only 33% of those patients who were able to achieve their LDL-C levels. So what happens now to the 67%? So that is actually what we mean when we say unmet need in the lipid management. But who are the population who belongs to that 67%? So these are actually patients who are very high-risk patients, especially those with familial hypercholesterolemia, that even though they've been taking a maximal tolerated dose of statins, plus they've been taking ezetimibe, still, di gihapon nila makontrol ilahang LDL. And also, the newly discovered culprit in the lipid management, which is the PCSK9 inhibitor, or the protein convertase subtitling type 9. So PCSK9 reduces the number of LDL receptors on the cell surface, and it increases the concentration of LDL-C in plasma. So what is a PCSK9, by the way? So it's a serine protein convertase enzyme. So it is expressed in hepatocytes, kidney mesenchymal cells, intestinal ileum, colon epithelia, as well as the central nervous system. So this PCSK9, they regulate hepatic LDLRs, which bind and internalize LDL particles. So there's a loss of function variance associated with a lower risk of CV events. And PCSK9 also represents a therapeutic target in dyslipidemia. So this is actually the unique mechanism of action of Upata. So it is a fully monoclonal antibody that binds to PCSK9. As you can see on the picture, it directly binds to PCSK9 to give way for more LDL-C and LDLR receptors. So also here with Amgen, we invested a lot of our clinical trials in our clinical studies. We cover not just the safety and tolerability of the product, but we also provide extended studies. So for tonight, we will be highlighting one of our clinical trial, which is Delaplast. So with that, I would like to turn the floor over to my partner, Carlo, for further discussion. Thank you so much.
Thank you so much, Erica.
Welcome.
Let me just share my screen. So basically now the question is to whom we will be able to give Leukomab. So based on the discussions earlier by Dr. Romance and Dr. Mabulao, by the way, thank you so much, doctors, for that very informative lecture. Leukomab is currently indicated for patients with primary hypercholesterolemia or mixed dyslipidemia but still uncontrolled on background therapy of statins and ezetimibe. So again, these are your very high-risk patients which are not yet at goal, as mentioned by Erica earlier, these are the patients who have unmet needs, and we hope that with the addition of evolocumab, you will be able to see that evolocumab can give 75% further reduction on top of your statins. Another type of patient that will greatly benefit from evolocumab are those patients with um, intolerance to statins. And the good thing before kasi doctors, di ba, these patients who we tend to adjust their treatment. Like may I have doctors before telling me na may MWF naka-statin, merong every ilang days. So we adjusted for them to be able to still get the effects of statin despite of their intolerance or the adverse events. But for now, with evolocumab repata, these patients now they have a chance to lower their LDL-C without the 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 adverse events, the muscle pain, and very tolerable and very safe yung evolocumab on these types of patients. And lastly, for heterozygous and homozygous familial hypercholesterolemia, we understand that identifying these patients might be very difficult as of now because we don't have any genetic screening available in the Philippines. But I also want to inform everyone that we are partnering with the Philippine Lipid Atherosclerosis Society, and we are also conducting FH workshop to be able to help these patients which are not screened yet and be able to have more FH champions in the Philippines, doctors from different specialties, especially cardiologists and endocrinologists. We will be inviting also. We will also be inviting to our FH workshop. Maybe I could uh, give the invitation also to extend the invitation also to Erica for Eastern Visayas doctors. And as I've said, or as Erica said earlier, we will be focusing on this patient. So evolocumab significantly lowered LDL-C on patients on background statin therapy. That is whether 140 milligrams every 2 weeks or 420 milligrams once a month. But for the Philippines, only 140 milligrams every 2 weeks is available. And as I have said, LDL-C lowering was significantly greater in patients receiving evolocumab or Repata combined with atorvastatin at 63 to 75% than in those receiving ezetimibe combined with atorvastatin at 19.3. So patients achieve less than 70 milligrams per deciliter. Up to 94% of the patients with moderate intensity statin, and up to 95% of patients on top of the high intensity statin. So I've said evolocumab also was very tolerated on top of different statin treatments. So just to give you a figure lang, doctors, on how evolocumab was able to affect our patients in this trial, in the Laplace trial. As you have seen, we have the high intensity statins of atorvastatin and rosuvastatin, up to 75% reduction, further reduction in LDL-C when combined in this high intensity statins. And lastly, I also want to show you this one, that for atorvastatin also combined 80 milligrams, we have 75% treatment difference. So when added to statins, evolocumab delivers intensive LDL-C reduction in patients with primary hypercholesterolemia or mixed dyslipidemia. You might also ask me or ask our representatives or doctors, um, yung bang ipata after ng statin or after ng ezetimibe. So based from the guidelines for doctors, if still your patients are not controlled with statins and ezetimibe, and you need another agent, you have now the option to give Repata on those types of patients. Except for the patient's doctor na may intolerance sa statin, that you go straight to ezetimibe and still not controlled, then you have to follow them. And with that, just want to thank everyone for this opportunity given to Swilling Pharma, Amgen, for the chance of giving you more information on this relatively new drug for patients with very high LDL levels and very high risk patients. So with that, maraming salamat po sa inyong lahat. I don't know if daghang salamat is also the proper term. Maraming salamat.
Okay, so thank you, Ma'am Erica and Sir Carlo.